on to radiation dose, because that was another area of concern that was brought up by CMS or Medicare. And I'll give you a perspective on dose in that the average annual natural background dose is at 3 millisieverts, and I want you to remember that number. If you live in a high elevation like Denver, you actually are exposed to 4 times that. So your dose is at 12 millisieverts. And we don't see any higher incidence of cancer induction in people living in Denver. The effective dose range, you can see in all the papers, the trials that I've listed here, documents that the dose for CTC, and some of these are older studies, ranges between 5 to 8 millisieverts, so it's already quite low. Currently, with the introduction of additional dose-lowering techniques like iterative reconstruction technique, which we are currently using, we've gotten the dose for CTC down to about 3 millisieverts, and at some sites, they've even decreased further by decreasing the effective MAS. So we clearly, I think, are averaging close to the annual background dose. In terms of risk of cancer induction, you can see that this is a graph from the Brenner and Hall article from New England Journal of Medicine, looking at the age at time of the CT study compared to the estimated lifetime risk of dying from cancer. There's an acute decrease, a drop, starting at the age of 35. And just as a reminder, CTC screening for colorectal cancer is recommended to start at the age of 50. So we're certainly beyond that point. Also, as a reminder, only the abdomen and pelvis are exposed in CTC. Only the lung bases are irradiated. No significant portion of the lungs should be irradiated during a CTC. And bronchogenic carcinoma is actually one of the primary carcinomas that are caused by radiation. This is a statement from the Health Physics Society that they published in 2010. Below 50 to 100 millisieverts, the risks of health effects are either too small to be observed or are non-existent. So clearly we're way below this level. This was a paper that we published in AJR in 2011. This was funded by the NCI. Amy Barrington de Gonzalez was the first author. You can see that Rebecca was on this as well as I. And this was actually presented at the FDA panel by Amy a couple of weeks ago, and I think it had significant impact. And this was a study looking at the benefit-risk ratio of radiation-induced carcinomas using CTC. So they used the BEAR-7 report, and they used microsimulation models, 3 different ones. They drew the effective dose from the Akron CTC protocol. And I think of note was that they also included radiation risk from any additional imaging that might have been performed for incidental extracolonic findings from the CTC. This is a really busy slide, I know that, but what I want you to focus on is the benefit to risk ratio range here, which you can see is very favorable, between 24 to 1 up to 35 to 1. So the results showed that the estimated radiation-induced cancers from CTC screening every 5 years was at 150 per 100,000 patients, whereas the number of cancers prevented from CTC screening was over 5,000 per 100,000 patients. And this resulted in this very favorable benefit to risk ratio. And so the conclusion was, and this was again highlighted at the FDA panel meeting, was that the benefits from CTC screening clearly outweighed the radiation risks. Now, what are some other things that we can do to decrease dose? And I think, as in any other radiology or imaging test that we do, we have to make sure we're performing the right test on the right patient. So we don't perform CTC if the patient needs to go on for a colonoscopy anyways. So inflammatory bowel disease patients will need to go on for their annual random biopsies to rule out malignancy. CTC is not suggested, also for polyposis syndrome patients. We've lowered our effective MAS pretty aggressively, so that in the supine position we go with what the national guidelines state, which is an effective MAS of 50. But additionally, in the prone position, I feel that we can decrease that even more, so we've cut that down by half, down to 25. And it does affect, I think, evaluation of extracolonic findings, but at least in the supine position, you're able to, I think, detect any significant extracolonic finding. You have to have properly trained staff. So your technologists, whoever's performing the distension for you, should be well trained so that you limit the number of rescans that have to be performed. And then finally, use iterative reconstruction technique because it really makes a difference in the dose reduction. And just to show you that I pulled this off of our scanner, and you can see the 0% ACER, so that's basically with filtered back projection at 50 MAS compared to a 40% ACER image with 25 MAS. The dose reduction is significant, from 7 millisieverts down to 3 millisieverts, so close to a 60% reduction in dose. Now what happens when you decrease dose so aggressively is you can see that the ACER kicks in. And so when we decrease from 40 MAS down to 10 MAS without ACER, you start to get this very irregular, sort of nodular wall with the ACER that tends to smooth it out a bit, but without, I think, obscuring polyps. Additionally, if you look at that top line where it's without ACER, you can see you get these intraluminal artifacts, or what we call floaters. But with the ACER, these actually disappear. And I think that it really makes a difference in being able to pick up the small polyps. Again, I pulled this dose report off of our scanner, and you can see that the DLP is at about 200. When you multiply that by the conversion factor for abdomen pelvis at 1.7%, some multiply by 1.5%, this is what gives you the 3 millisievert effective dose. Now, and I mentioned the effect on extracolonic findings. So if you look at the image on the right, the 25 effective MAS, I think that you would admit that it looks noisier, slightly less appealing, but it's unknown whether it actually detracts from your ability to determine that that's a cyst. Clearly that is a cyst on the 50 effective MAS study, but with a smaller lesion, would you be able to characterize the lesion as well? And it's not so clear. And that's a study actually that we're performing currently at the VA looking at this.